Good morning, everyone. My name is Dev, and my review is about the prognostic significance of postoperative hyperbilirubinemia in cardiac surgery. It's a project that's driven by the Department of Anesthesia and Pain Management at the Royal Melbourne Hospital. And I want to say a big thank you to my supervisor, Dr. Perry, for giving me this opportunity to do this narrative review. Now, I was never really a fan of PowerPoints, and I wanted to make this a bit interesting for you guys. So let's try something a bit different. To give you the background, I have to take you back to the 1950s. It was the decade that penicillin was made. The oral polio vaccine was being given for the first time, and more importantly for my project, the cardiopulmonary bypass machine was made. If you didn't know what that was, it's that thing that patients are attached to that functions as a heart, lung, and circulatory system. Now, fast forward to 1967, surgeons noticed that after cardiac surgery, their patients were turning a bit yellow. And I don't mean the kind of yellow that you or I have seen for the past several years. What I mean is jaundice. They called it post-pump jaundice. We now call it postoperative hyperbilirubinemia. This 1967 study reported an incidence rate of nearly 10%. Now jump to 2019. The rate hasn't changed at all despite the advancement in bypass and anesthesia technique. On top of that, researchers noticed that mortality and morbidity was higher in those patients that did develop post-op jaundice. However, its prognostic value is still debated because some studies suggest there's no association with mortality or morbidity. So this narrative review aims to evaluate the utility of postoperative hyperbilirubinemia in predicting in-hospital mortality, long-term mortality, and ICU and hospital length of stay in those patients undergoing cardiac surgery. Using the terms cardiac surgery, hyperbilirubinemia, mortality, and morbidity, we constructed a comprehensive list of keywords, and we searched PubMed, Embase, and Medline. Our search strategy was pretty long, but that's only because we wanted to include absolutely everything. And we did, because now I had to screen 3,327 studies, and that was after the duplicates were removed. But that being said, 2 weeks later,
Can you believe it? Thank you very much.
we also had a pretty strict inclusion and exclusion criteria. We only looked at cohort studies that measured post-op bilirubin and commented on mortality and morbidity. We only looked at studies that involved bypass grafts and valvular surgery and excluded the remaining. The patients had to be 18 years or older and not pregnant. And we did not include other types of studies like case reports or other narrative reviews. Ultimately, my narrative review was based on 12 studies. So, what did we find? Here are some interesting things you have to know. We looked at 12 studies with a total sum of 3,876 participants, and interestingly, each study reported a different incidence rate of post-op jaundice. One study even reported an incidence rate of 51%. And also, the researchers differed in how they defined postoperative hyperbilirubinemia. Most went with the threshold of 3 milligrams per deciliter. However, some set the threshold at 2 and one study at 2.8. Also, most studies commented on what type of operations their patients went through. Most of them were bypass grafts, some were single valve surgeries, and some were multiple valve surgeries. Of the patients that did get post-op hyperbilirubinemia, most actually peaked early in their bilirubin levels around day 2, while some patients peaked around day 7. Now let's look at some outcomes. The consensus among all studies was that there is a strong association between postoperative hyperbilirubinemia and in-hospital mortality. Here's a summary table of all the odds ratios describing in-hospital mortality. We can see that the respective confidence intervals are wide but don't include the number 1. This indicates that the relationship between postoperative hyperbilirubinemia and in-hospital mortality is significant. All but one study, that is. Chandra et al., who observed no deaths in the post-op jaundice group, actually reported a confidence interval that does include number 1, so we say that their findings are inconclusive. 2 studies looked at long-term mortality. One study showed that patients with new onset postoperative hyperbilirubinemia had a survival rate of only 37%, whereas those with normal levels had survival rates up to 57%. Another study performed a Kaplan-Meier analysis, and that showed a 60% decrease in survival rates in patients who had moderate to severe postoperative hyperbilirubinemia. all studies reported that patients with elevated bilirubin levels had longer ICU and hospital length of stay. An interesting thing to note is that those who peaked early actually had longer ICU length of stay, and those who peaked much later had longer hospital length of stay. Here are some other cool results. Firstly, as you know, there are two types of bilirubin, conjugated and unconjugated. We found that patients with early post-op hyperbilirubinemia had higher levels of unconjugated bilirubin. Those who peaked much later had higher levels of conjugated bilirubin. Many types of surgeries were performed, but post-op jaundice was found most commonly with valvular surgeries, particularly when the mitral valve was involved. Patients with longer bypass time, cross-clamp time, and those who received more transfusions were more likely to get post-operative hyperbilirubinemia. Now let's discuss that. We know that hyperbilirubinemia patients had higher mortalities, but what were they dying from? It turns out they were dying from a number of things, such as multiple organ failure, respiratory failure, septic shock, liver failure, infection, and acute kidney injury. However, the most common causes of death in patients with high conjugated bilirubin levels seem to be multiple organ failure, shock, liver failure, and acute kidney injury. This suggests that postoperative hyperbilirubinemia is an indicator of serious underlying disease rather than a direct cause of death itself. So what are some risk factors for post-op jaundice? Well, firstly, the bypass machine itself induces a state of hypotension, hypoxia, and hypothermia on the abdominal organs. This leads to hepatic injury and therefore leads to postoperative hyperbilirubinemia. Second of all, giving more blood transfusions perioperatively increases the rate of red blood cell hemolysis. And as we know, red blood cells break down into unconjugated bilirubin first and thus cause hyperbilirubinemia. And thirdly, valvular surgery, especially when multiple valves are being operated on, seems to be a risk factor. This is probably because the severity and complexity of valvular surgery, along with its increased bypass time and blood requirements, predisposes patients to post-op jaundice. The early unconjugated bilirubin phenotype in most patients is likely a result of the transient physiological insult by the bypass machine, the anesthetics, and the blood transfusions. The conjugated phenotype in the late peakers is most likely a sign of serious hepatic dysfunction, and therefore poor prognosis. This suggests that the prognostic value of conjugated hyperbilirubinemia alone is worth exploring in the future. Our review had some limitations though. Only 2 studies provided maximally adjusted odds ratios, so therefore the risk of residual confounding bias is high in most other studies. This is reflected in the PROBAS scores, which is a quality assessment criteria specifically made for prognostic studies. Number 2, the studies varied with their bilirubin surveillance periods. Some authors measured bilirubin for 2 weeks, while others measured for only 7 days. So a future recommendation is to have a standardized postoperative hyperbilirubinemia surveillance period. And thirdly, not all studies differentiated patients who were treatment naive from those who received cardiac surgery in the past. This is a potential confounding factor in predicting mortality and morbidity. And also, although our odds ratios were significant, the confidence intervals were pretty damn wide. This suggests that we need more large cohort studies to achieve higher precision. Postoperative hyperbilirubinemia is a grave sign, especially if it's persistent. It should prompt the clinician to increase monitoring and to investigate for serious underlying disease. After all, LFTs are pretty cheap and they're routinely performed after cardiac surgery anyway, so postoperative hyperbilirubinemia has the potential to be a novel yet cost-effective tool in identifying at-risk patients. Future research should focus on phenotyping post-op jaundice as either conjugated or unconjugated and early or delayed to see which combination gives rise to the least favorable prognosis. So in conclusion, postoperative jaundice is a promising prognostic marker of mortality and morbidity. The timing and phenotype of the hyperbilirubinemia can definitely help clinicians identify patients who are most at risk of adverse outcomes. And persistent hyperbilirubinemia should sound alarm bells for the clinician of impending liver failure.